quorum now. Perhaps we can start. We have about 40, 50 people who've already joined in, and there are more joining in as we speak. A basic few housekeeping rules for everybody. Please ensure that you have put your video and audio switched off, put on mute, and please try and ensure that you do not contribute to any kind of a disturbance with the flow of the proceedings. It may be inadvertent. I'm sure you wouldn't do it deliberately, but please be mindful, because phones ringing in the background and people chatting in the background can disturb the flow of the proceedings and disturb the speaker. You know? So I would just urge you to do that, and I will request the host to ensure that everybody is on mute at all times. I think we are good to go. Dr. Menon, are you on board? Can you hear me?
Yep, I can. Thank you so much.
Lovely, great, excellent. So it gives me great pleasure to introduce Dr. Jayakumar Menon. He is a multifaceted guy who's an academic, who's a clinician. He's got a little bit of a social bent of his mind as well. He volunteers with an NGO, and he does good work. And he at the moment is currently working as an adjunct professor in the Department of Psychiatry and a consultant in the Neuropsychiatry and Geriatric Care Clinic at Srihar, Chennai. He is having his own private consulting at Chennai. He is the clinical lead in Anbagam. Am I getting that right? Anbagam is an NGO involved with the rescue, rehabilitation, and reintegration of the homeless and the wandering mentally ill. So that's the social part which I mentioned, and that's a very commendable job indeed, because these are the underprivileged who probably never get adequate representation despite of what they deserve. Dr. Jayakumar has a core interest in teaching and research. That explains why he is here with us today. The focus of current research being cognitive disorders, cognition and schizophrenia, and Parkinson's disease. He is a section editor of Neuropsychiatry, IJPM. There's an Indian Journal of Psychiatric, what is that, IJPM? Jayakumar?
Indian Journal of Psychological Medicine is by
Psychological Medicine. Okay. And reviewer of the national, he is a reviewer in various national and international journals. He is an alumni of Calicut Medical College, Madras Medical College, and St. John's Medical College in Bangalore. He's completed his fellowship in psychiatry from Adelaide, South Australia. He's worked as a consultant psychiatrist at the Royal Adelaide Hospital and Glenside Hospital at Adelaide. And he works in India most of the times, but when his alma mater does tend to draw him out, he tends to go off to Australia as well for a few discourses. So I'm delighted to have the pleasure of introducing Dr. Jayakumar, and I'm even more grateful to him for having accepted our kind invitation to share a few of his thoughts with our postgraduate students. Dare I say, your audience today is a lot more than just postgraduate students. There are many consultants who have now taken a liking to our discourses and our lecture series. So as my teacher used to tell us, we are students for the rest of our lives. So just because we've got our postgraduate degree under our belt doesn't mean we have to stop learning. And that's the reason why we are seeing more and more consultants, more and more senior psychiatrists who are logging on and taking advantage of these discourses. And I'm sure you will do us justice, and you will be able to enlighten us with a completely different perspective. Once again, I invite, and without any further ado, I request you to take over the proceedings.
Thank you so much, Professor Rashmin. I hope I'm audible.
Yes, you are.
Yeah, just give me a minute. I'll just share the.
We shall be having a Q&A at the end of the talk, so I will request everybody to post their questions in the chat box, and we'll try and address as many of them as we can towards the end of the discussion. Right?
Yeah.
Over to you, Jayakumar.
Yeah, thank you so much, Professor Rashmin. It's been a privilege and honor. I'm really honored to be invited for a knowledge series in psychiatry, where many of the stalwarts in psychiatry have spoken before, and then much more capable people are coming after. Really looking forward to Professor Andrade's lecture next month. Now, when I was first asked, I was not sure what prompted the request, but again, Professor was quite kind enough to give me the opportunity to choose a topic that I prefer. And then this was decided it could be diagnostic formulation. Now, this is something part of our work here in Chennai, where I've been trying to get to have some more interaction with the postgraduates here. So we have quite a good number of brilliant students and brilliant colleagues of mine who have been working together to try and improve the training standards as well as the teaching methodology. So this was part of a workshop series that we were conducting at the Kilpauk Medical College with my friend and colleague, Dr. Daniel, also later in Ramchandra. So I thought this would be a good one to extend it to a larger audience, and that too with psychiatric trainees. It's always a pleasure to talk to students and trainees, and I completely agree with what Professor Rashmin had said about the idea of lifelong learning, which as a professional, I think is the commitment we all need to have. So without much delay, I'll just move on to briefly onto the next slide. So just to be, this just an overview of some of the centers that I've had the opportunity and the privilege to be part of, including Calicut Medical College, Institute of Mental Health, Madras Medical College, Central Institute of Psychiatry, St. John's, and then Royal Adelaide. I respectfully remember my teachers who have contributed to the learning and continue to provide learning opportunities. So today's presentation primarily it would be under these headings. Now, why I wanted to highlight this is because diagnostic formulation as such is a term which I find, at least studying in India, we were not quite much familiar or not taught to that extent than what we would see in many of the overseas training programs. Now, I don't know why that is, because there's been a difficulty in conceptualizing what diagnostic formulation is. And also there was not much of significance given to in the clinical presentation, whether it is during the routine clinical presentation or at the exam time. Much more focus was on the mental examination and a diagnosis rather than the formulation. We'll see why this is important. Going through then the biopsychosocial model of illness, which I feel is more and more being accepted as the appropriate approach in recent times, with after a brief period of neglect towards it from the 1990s. We talk about the integrating the biopsychosocial model in formulation. Then I also take you through some of the methodologies, how we could go through the clinical interview. We use the principles of clinical reasoning as a tool for diagnostic formulation. Then we need to develop some basic structure. There's no hard and fast rules here, but some basic structure which would form the skeleton on which you could add the flesh and the other external appendages and form a complete formulation. at the end. So usually, as I said, this is usually done as a part of a workshop series. So I usually give them, with my colleagues, trainees, colleagues, a few case histories, and then help them work with the diagnostic formulation, which is what we were taught part of our training as well. Maybe if time permits, I was informed this is a 60-minute lecture. If time permits, I would, if it can be, and I was also informed could be a little flexibility could be there. So if people are interested, you could go through one or two case histories at the end, very briefly. So to start with, I just like everyone, actually postgraduates, to just have a minute to think about a particular situation. Thought experiment is usually done in physics, where you have an assumption and then it takes you through the logical conclusion at the end. I want you to think about a close friend of yours from childhood, somebody who has been with you from, let's say, from your Balwadi days or your LKG kindergarten days, and who has studied with you up to your +2 and then has taken a different career pathway. Probably you seem to have, and you know inside out about him, is the closest friend that you've had. Probably time and distance and geographical separation would have kind of diluted the ties, but then you not had much contact for the next 4 or 5 years, and then you're a trainee psychiatrist. And in your emergency room, while you're on call, one day, suddenly one person comes in and you suddenly realize this is your friend. And he has, and when you realize with the horror and the shock, and you realize that he has thought disorder, he has delusions of persecution, you have auditory hallucination, second, third person, he is completely disorganized, and then you conclude the person as schizophrenic. Now then, just imagine, is that what you would do, or would you be doing something more than that? So this is where the diagnostic labeling assumes a kind of a negative consequence when in practicing psychiatry. Now, I'm not talking against making a formal diagnosis, but when we limit to a diagnosis alone, we tend to miss a larger picture. Just like, you know, the friend with all his strengths and all his skills, his interests, and his future ambitions, and what illness has done to him. And then your thought would be how to get back to him, to how we knew him. And that is all that is there in understanding about diagnostic formulation. Let's move to the next phase, which is just to understand what exactly this is. I'm just elaborating on the initial introductory part. So where does diagnostic formulation stand in modern psychiatry? Now, we might be people who are interested in various aspects of psychiatry. We might be a biologist who would vouch by the neurotransmitter theory, the networks in the brain. We might be people who vouch by the benefit of medications, which can correct. We might be people who would look forward to finding a solution to some of the long-standing illness, which currently do not seem to have a complete cure most of the time. So where does it stand in modern psychiatry? So a few thinkers and leaders in psychiatry sat together and then had this commission on the future of psychiatry. This was published in Lancet, and there Professor Bugra is, as you know, is a WPA head, and he previously was head of the Royal College of Psychiatry in London. Now, this section actually states that the psychiatric formulation is broader than diagnosis alone. There's a section on what psychiatric formulation, diagnostic formulation psychiatry mean. So it takes into account the social context, contributory risk, and protective factors, and developmental change. And say these factors are relevant to formulation of the management plan, selection of appropriate treatments, and prediction of adherence and prognosis. And that point is important because I think the most important role that we do as a clinician, in any field, is to prognosticate. And you must be able to give an idea about what the prognosis could be. And diagnostic label by itself may not be able to do that. So he also continues to state, the team states that this approach is unlikely to be replaced by a purely biological or investigative approach, and in its ideal form should continue to be based on an integrative biopsychosocial cultural formulation. So it's very clear about where it stands in modern psychiatry. This is part of the first lecture in 2017. So it's still valid. It's not changed as of now. All right. So what exactly is a diagnostic formulation? Let's go to that in little detail, but try to understand the concept as such. So in 2 words is an explanatory hypothesis. Both words are important. You're just hypothesizing a person's condition, a person's status. Now, hypothesis could be wrong. So an element of uncertainty is always there. That is perfect. Well, that we, as clinicians, as psychiatrists especially, we need to entertain the uncertainty as a quality, because most of the time, if it's too certain too early, that is when the problems come up. So diagnostic formulation helps you to keep up a hypothesis-based approach. It goes beyond the diagnosis. We'll see how. Then it conceptualizes the patient's current and future clinical picture and etiology as well as management. So having a good formulation helps you give a better understanding of the patient status and also formulate a better management, which is why it is more important, or let's say more significant than a diagnosis. Now, it does it in the context of biopsychosocial cultural domains. You may ask why. We'll go to see that. At least there's a general acceptance that not only psychiatric disorder, most of the disorders have these components which are significant and interconnected. So formulation includes all of that. All right, so what about its role with learning? We talked about lifelong learning principles. Now, there's no doubt about it, diagnostic formulation, it essentially is a skill. So many times we don't differentiate between knowledge and knowledge base and skill sets, which are slightly different. Now, we may have an excellent knowledge base, but we may not have all the skills required. So sometimes we need to sharpen our skills. Sometimes we may have to do additional learning. So skills required to formulate or conceptualize a case is refined throughout one's career. Now, an MSc, medical examination is a skill which you, as students or trainees, should completely be at ease at the end of your training. Now, there should not be a case whereby you continue to learn your MSc further, and once you start practicing, better learn it before, because otherwise you tend to get into problems. But formulation is, in that way, it's not limited to one particular. Obviously your interviewing skills can be honed throughout your career, but certain skill sets, it takes time to develop. So in that way, if anybody feels at the end of the lecture, oh no, this is too complicated, I can't even do that, just believe me, I was in the same situation as you. We all were in the same situation. We just go through the process and then improve this. And I wouldn't claim I have formulated as better as my colleague and friend Dr. Daniel here in Kilpock. So he is much more conceptually clear in some of these aspects. It reflects higher order thinking, which encompasses the abilities to understand, apply, analyze, and synthesize knowledge. These are acquired during a psychiatric training. Now, many times these are not emphasized, even though we might be doing it reflexively. It's sometimes good to know where are the areas that we need to probably put in more inputs. So that tells you the importance of diagnostic formulation assets. Now, coming to the biopsychosocial model of illness, and everybody talks about this biopsychosocial model, but what exactly was that? Now, this name, again, might be quite familiar to some of the people from institute, which are very particular about the biopsychosocial model application. Like, for example, CMC Vellore, I know, for that matter, has been proponents of this for quite some time. It religiously follows the application as such. Now, George Engel in 1980 developed this as a corrective to the narrow biomedical model. You need to know a bit about, I'm sure you all know the background about psychiatry moving from asylum era to more of long sessions and analytical era, to that of first drug and then neurotransmitter era and then the brain models. There was a stage in which where people thought there could be a clear answer to some of the pressing psychiatric problems, and the biomedical models took strong hold. Now, it did not take the psychiatric care to a particular level that they expected. So Engel was quite disturbed by that. And if you look at, and he's a psychiatrist, so he proposed this apparently as a correction to that narrow biomedical model. He wanted to counter the classical science approach. People are applying scientific approach whereby uh, they thought illness and behavior could be broken down into simple parts and you could have a linear causative explanation, which was not the case, which could not be, as we know with most of our psychiatric disorders. So he tried to link the biological, the psychological, and the social factors into a conceptual whole, which was the biopsychosocial model. So in his classic paper in the 1980s, I'm not going to the whole issue altogether, but just to give you an overview, this was explained not on a psychiatric disorder, but on a cardiac patient who presented with angina to an emergency department. Engel clearly demonstrated the multiple layers at which the illness presentation happened and how various factors interacted to produce a catastrophic outcome just because certain things were not looked into. Now, that's an important paper which you'll be able to go through. I'm happy to send it if anybody is interested in reading about that. But what he essentially did was he wanted to conceptualize this, the illness in a cross-sectional model, in an integrative model, whereby starting from the molecular changes to the cellular changes to the systemic changes to the interaction between individuals. Here, the doctor and the resident who was a little in a hurry to complete his job. And then there was a argument which led to panic attack in the person, which led to he becoming a full-blown myocardial infarction and then having an arrhythmia. So he explained everything and then demonstrated very clearly where these things come together and then highlighted where things could have been done differently and how each component could have been done differently. Now, this kind of opened up a whole gamut of research into how biopsychosocial model could be applied in various disorders in psychiatric as such. And each component had experts talking about their role. Now, this created a problem. Let's see what were the reasons for the lack of popularity of the BPS model later on. Now, imagine somebody coming with an emergency. You are not going to go through some 10 layers of issues which could have contributed to that and then think what needs to be done. It has to be done then and there, the emergency treatment. But in that way, it was very complex to trace connections beyond 2 to 3 levels in a cross-sectional manner. Now, coming to psychiatry, again, it appeared to be too theoretical. So there were so many incompatibilities between theories and theorists. And everyone claimed there to be a better model. And we do see that even now. There's no concept of a multidisciplinary approach to care in many places. And there's always this conflict which happens. Subspecialization was the other reason. So there are people who specialize more and more, knowing less and less, which is a dangerous thing. We see that happening in many of our medical field too. And then the most important thing, coming from the DSM-3 onwards, ICD-9 and 10, the modern psychiatric diagnosis is definitely acausal. Like if you have the diagnostic criteria for depression, you don't even have to. You just do a checklist interview, pick 7 symptoms out of 9. There you are. You're diagnosed depression. You start a medication. You don't even have to bother about what exactly. He has got depression and you treat it. Most of the time, that is what happens. Now, this became so popular that it stood against the biopsychosocial. You don't even have to have a cause. Then why do you bother about the biological, psychological, and social causes of the illness? It was difficult to kind of comprehend this in the modern understanding of psychiatry. But let's see what DSM has to say about diagnostic formulation at the end. You'll be surprised. I'm sure some of you would have read about it, but let's see. So then comes the larger challenge. How do we integrate the biopsychosocial model in diagnostic formulation? So this is a challenge. As you can see, you have the biological factors, psychological factors, social cultural factors. All these are important. As we know, we have theories, various models of causation of illness. So how do we integrate that in case formulation? Because the case formulation requires a comprehensive picture and requires all 3 factors. So kind of simplify into 4 questions that you can ask with every patient coming in. That's the first step. So I'll take you through the process and I hope you'll be able to kind of assimilate some of these things. But as I said, it's better, it's always good to go through further and practice more and more. But this is a simple question which anybody can ask. For example, what are the predisposing factors? So it essentially asks this question: why is this person vulnerable to this problem? Now, many people have the same issue, same stressors, but then some people become unwell. Why is this person specifically vulnerable? And what are the factors, vulnerable factors in him, which makes him sick? The second important question you can ask is, okay, why now? Now, this person did not come to me 1 year ago. It did not come to me, let's say, 1 week ago. But why is this person having the symptoms now? And why is this person presenting to this therapist or doctor for treatment now? So there could be some factors which would have precipitated. Now, if you look at it, it could be a person, DUP as a concept in schizophrenia. That's an important indicator of prognosis. Now, we have people who might come even now with 2-3 years of no treatment, and then suddenly come now. Why? There might be a violent incident. So that could be the precipitating factor. There could be a significant loss of weight. There could be a medical crisis. So any of these things, the precipitating factors are important. Or a person with a first episode psychosis, relatively doing well, suddenly has a significant stressor. That stressor itself is a precipitating factor. Then we ask this third question, perpetuating factors. Why is this person still ill? Now, he was not ill. He was ill for some time, but then he does not seem to be recovering. 10 people like him has recovered. So we need to know what are the factors that maintain this illness. And last but not the least, the protective factors. Now, I have 5 patients with this particular diagnosis, but I have this man doing remarkably well. So what are the factors that make him more resilient and make him better and the outcomes better for him? That's a question one has to ask. So then when you try to integrate it, it's again, try to give you an overview and pictorial idea about what we are trying to do. So George Engel had a more cross-sectional idea of the causation of the illness at various dimensions. Whereas in a diagnostic formulation, if you integrate the biopsychosocial model in diagnostic formulation, it is more across a time period. Now I'll show you how. Now imagine this is across events happening across a period of time. So we know most of psychiatric disorders. For example, let's take the example of schizophrenia. There are predisposing factors in schizophrenia we all know about. We have the knowledge base on that. So there could be 1 or 2 predisposing factors. It could be during pregnancy, mother's alcohol usage. It could be trauma. It could be birth injuries. Now, as a toddler, it could be deprived. Social deprivation is known to be a trigger. As an adolescent, probably lack of proper education. It could be, again, violence and drug abuse, whatever. As a young man, then there's a precipitating event which brings about first episode of psychosis. Then you see the illness course, we start treating, you see some of those factors which are maintaining the illness, we call the perpetuating factors. So, and then finally the prognostic factors or the protective factors. So this gives you an overview of how we conceptualize the diagnostic formulation across a period of time. This is what is called a timeline. So contrary to what Engel has proposed, in a modern psychiatric diagnostic formulation, we see things over a period of time in a larger perspective, which gives us a better idea of what makes things, or what makes a person vulnerable, understand it better, and provide a treatment which is individualized to his specific needs, considering his strengths and his weaknesses. Okay, now this is a simple way for people who have not started using a diagnostic formulation, or you struggle to find factors which are important in formulating this person's understanding the predicament. This is a simple way of, usually you do a 3x3 matrix of predisposing, precipitating on one side and biological, psychological, and social aspects. You also add protective in nowadays, so you can fill in all the details. What are the biological predisposing factors? For example, if you have family history, the genetic risk, which is a biological predisposing factor here. The psychological, it could be a cluster B personality type. Emotional dysregulation could be one as a psychological predisposing factor. A social factor could be a relationship breakup, or it could be a precipitating factor. It could be related to long-term homelessness, for that matter. So any of these things could be filled in, and you need to, what you can do at the end of your usual diagnostic interview is to draw this chart and then fill in as much as possible. You get your material for your diagnostic formulation. But it's not as simple as that. We'll see what else needs to be done. Now, this is expected. If you look at some of the training programs for undergraduates overseas, this is expected to be done by a fourth-year medical student. Now, I'm not sure if we get a chance to learn it even during our postgraduate training in most of the time. So that's the difference. So this is how important it is to develop the skill over a period of time, so that at the end of you coming out as a consultant, you are in a much better position to manage the clients. So the $1 million question, if there is one in diagnostic formulation, is this. So within the context of the clinical examination, formulation, as I've said, is a set of explanatory hypotheses which address this question. What is that question? Why does this patient suffer from this problem at this point in time? Now, all these three are important. This patient gives you individualizes to that particular individual, that person. The problem could be different. Now, I'll again try to explain that. For example, somebody with a lifelong diagnosis of schizophrenia has had a big fight with his brother, who was his caretaker, and you see that quite often. I'm sure you would have seen that in Mumbai and Mumbai as well. Anywhere across the world, that's the case. Had a big fight, and the family throws him out. Now, he has no place to go. He tries to kill himself just by slashing his wrist, or just took a glass piece and then stabbed himself. And he came over. Now, when you interview a person, you would not be looking at the presence of delusions, hallucinations, or diagnosis of schizophrenia as a priority. Now, you would be looking at the homelessness and the precipitating factor as a major issue, which has created this particular problem, a patient presenting to the ED, emergency department, and at the point in time. So the management as such would move from somebody who's been quite regular with his medication, probably even on a depot. Your management is provide some social security to that person. You talk to your social worker colleague and then engage with the NGOs and then find out there's a temporary shelter. This is what we should do, because we don't have a community health service in this part of the world. So this is something which, and the family is not willing to. This is something which we will do as a priority. So that exactly is reflected. You get this answer from this particular question. So the essential task in formulation is to highlight possible linkages or connections between different aspects of the case. Now, how do we do that? We're just going to see in the next few slides. Now, before we move to developing or talking about a definite structure for diagnostic formulation, let's understand our regular work as a clinician. It's very important as what we do as a clinician. It's fascinating, but I hadn't even thought about it much unless I had this opportunity to have training, and then some of the excellent clinicians in Royal Adelaide Hospital, including my mentor, had explained how very commonly we tend to ignore some of the basic aspects and then tend to go way away from what exactly is required. So clinical reasoning, and that's again a skill set which one acquires as we get more and more exposed to the field and more we practice. So the art of clinical reasoning essentially contains three aspects. One is a diagnostic knowledge. That's a knowledge base. We have entire, some of us maybe thorough with the entire coding system in their ICD or DSM, the entire diagnostic criteria. That's a knowledge base is extremely important in clinical reasoning. And then the second component. Now, in the same diagnosis, the etiology could be different. So the etiological knowledge base assumes a second important component in your clinical reasoning. And we'll see how that is developed. Third part is the treatment knowledge. Now, I won't be highlighting the treatment component, the treatment knowledge part in the diagnostic formulation, because that is essentially is another workshop and essentially another lecture based on the diagnostic formulation. How do we do a comprehensive treatment plan for the person? This is what most of the Royal College exams would expect you to do. Now, what's the connection between these three components? Let's again have a look. So we primarily focus on symptoms in psychiatry. The symptoms are associated with symptom attributes, for example, depression with duration, the diurnal variation, severity. Then there are certain clinical phenomena which is also connected to symptoms. For example, a depressed mood could be part of, let's say, a guilt, which is due to some thing which has happened in your life. So we have certain clinical phenomena which is connected to the depressive symptom, and then you make a diagnosis of clinical depression. So when you have clinical phenomena that you identify, then we sometimes have, we always connect that with some theoretical model which explains why this is developed in a particular person. Now, it could be guilt in some, it could be something else in another person, but we have a model which explains. That's the etiological model. So there's an explanatory model which gives an idea as to what this is in this person and why this is happening. It's not about diagnosing depression alone, it's about the clinical phenomena associated with that. Now, then you have the treatment component. That treatment component is essentially dependent on the explanatory model. If you are a biologist, you have a neurobiological explanation for it. Perfect. Your diagnostic formulation can be entirely biological, but then the treatment component is entirely biological as well. So it's not that we have to focus invariably on three different aspects and then get confused in the end. You could use what is relevant, but the art and skill of diagnostic formulation is to identify what is more important, what is more suited in that particular person. That comes from more and more of using the diagnostic formulation, understanding the person. Let's look at the 4 steps of clinical reasoning. I'm not going to give a theoretical discussion on all these aspects, deductive reasoning and inductive reasoning, but just give you an overview of that. So the first part is abstraction. I only highlight what we need to do. You all are doing that in part of your clinical interviewing, but just focus on some aspect of it. Now, abstraction involves eliciting individual symptoms. We all do that. We are pretty good at that. Many of us have all the checklist symptoms in our brain when you do an interview. And then sometimes we just verify and then categorize and then diagnose. Now, abstraction is essentially starting with that. You elicit each individual symptom, the clinical signs or the phenomena during the clinical interview. There's a difference between all three. We'll see what that is. So along with that, along with this particular symptom, we also need to elicit symptom attributes. Now, somebody says, I'm feeling sad. And you say, okay, you ask for other symptoms, it's all there, but it's only since yesterday, since one day. You're not going to diagnose clinical depression in one day. So you might have to look at the duration, you see the progress, the presence. So we also look at the symptom attributes with each and every symptom. That's extremely important. And we need to do that to get a complete understanding of that. So the second step, after you start with this process, what we usually advise trainees, or when you teach them about the psychiatric interviewing skills, is to start hypothesizing soon. You need to have your mind running parallelly. Now that is possible. You might think it is too complex. I can't even focus on one particular symptom. How am I going to hypothesize? But then you are doing it invariably. When you hear a symptom of, look, sir, doctor, I feel a little overwhelmed. Then you're thinking about immediately clinical depression, and then what other components are there. And you also look about some of the stresses. You keep asking about those aspects. We actually do that. But in more specific terms, 2 parallel processes need to happen. One, you generate a diagnostic hypothesis, which is helpful for your differential diagnosis. And also you need to generate an etiological hypothesis. So most of the time what happens is when you have a diagnostic hypothesis, we limit to that and we keep asking about some other symptoms and then don't go beyond that. The etiological hypothesis is so important because that would help us look at things which are not of the routine, help us understand things beyond what is evident, and also help you to explain the clinical phenomena better. Let's see how that is. If you have somebody with a depressed mood, the diagnostic hypothesis would be that it could be major depression. It could be depression part of the bipolar affective disorder. You may also think it is an adjustment disorder with depressed mood. It could be a borderline personality disorder with a crisis, with its emotional dysregulation. It could be also an organic mood disorder when you have elderly 60 plus coming in with first episode of depression. You may have to think about vascular and other etiology there. This is a diagnostic hypothesis which you would have when the person comes in. So you kind of develop that looking at the person's age, the mode of presentation, and how that, which is normally done. At the same time, if you look at some of the related clinical phenomena, for example, depressed mood could be associated with extreme guilt. As I said, it could be self-blame or shame. It could be related to the person might be coming in the context of an interpersonal conflict with a spouse. It could be related to victimization. Interpersonal difficulty could be at the workplace. It could be at the office space. It could be related to bullying and victimization. It could be with grief and loss. There's a recent bereavement, and also could be an existential crisis. If you are familiar with something, which I'm sure most of you would be reading through during a training. If you are familiar with the, say, stages of life, you might think about a particular stage in life where people might come with an existential crisis. So Erickson's model of generativity versus stagnation, or ego integrity versus despair, is something which you would automatically come to your mind and think, am I seeing somebody who's not happy with who he was? That's a good model to look, and he might be depressed, but you might help him better with understanding the context. So the third part after this is the deduction, which is what Sherlock Holmes was probably most an exponent of that. Now, what you do in deduction is you trace all the expected symptoms. If you have depression, depressed mood, then you look for ask for all of the symptoms, and then probably form a diagnostic hypothesis. You already have a differential diagnosis in mind. You might ask some other questions to confirm that. So that's the first part. So on the other side, with the etiological hypothesis, what you need to do, you give a probable etiological explanatory model. So this is where your knowledge base should help you. And there's no excuse for not reading about and learning about it. This is why one has to learn. And it's a continuing process. So if you read about basic theories related to depression, for example, with the same depressed mood, the person has severe guilt, self-blame, or shame. Let's say with a cognitive theory of depression, you might postulate that, okay, here's one guy who probably had very negative experiences, in early childhood. There's some events which created a core schema, which was activated with a current precipitating event. And then there's a depressive rumination. I'm a failure. I've never been successful. And you identify some of those core stock words that people use, and then try to kind of identify and then do the cognitive behavior therapy for that person. The same guilt, self-blame, and shame could be part of another individual who had a very hypercritical parenting style, who faced a hypercritical parenting style, and there's a internalizer for the parenting figure. This comes from the analytical model in psychiatry, where it will lead to probably the excessive superego, which is hypercritical, doesn't feel good enough, and then keeps blaming the person because we internalize figure. You might be going through the dynamic models and the analytical models just to understand, but this is exactly what we need to do to have the wider understanding of the person. We have certain hypotheses which would explain the clinical phenomena, not exactly the symptom alone. Right. So then comes the last part, where you just do that, which we are all good at. We match the relevant symptoms and clinical phenomena with each diagnostic hypothesis, and we pick and choose the best diagnosis based on ICD-11. And you can accept or reject the various diagnostic hypotheses. At the same time, when you're presenting for your final exam, you may want to give a differential diagnosis and give your argument as to this is the reason why I do consider this as a first diagnosis. I may not consider this because of so and so reasons. That gives a much better idea of your knowledge base and your understanding, your skill sets. Now, the other part, you may want to choose the best fitting etiological hypothesis. Let's see how we go about with that. So we have the diagnostic rubric at one end, and you have the etiological hypothesis at the other hand. So then what we need is, we need to look at what are the models, etiological models that could be used. And that is quite a vast area of knowledge base, which you need to, when you acquire that during a training. Formulation again requires a model-based knowledge that spans across the biopsychosocial domain. So again, this knowledge uses a set of hypotheses which can be derived from diverse theoretical models. This is where the theoretical knowledge comes in to help us understand a given clinical situation. So what are the models for formulation? Again, it can be with the biopsychosocial realm itself. You have the biological model. I don't want to get into details of this. You are experts in this. You know it uh, much more than trained psychiatrists would know, much more than some of us consultants. So genetic risk, the birth insults, neuroendocrine HPA axis, circadian rhythm, priming, kindling, all these things are used as part of the biological explanatory model. We have the psychological theories. Some of them are from the early 1900s: cell psychology, object-relations, ego psychology, cognitive theory, behavioral, Erickson's model, the interpersonal, dialectical behavior, all aspects which kind of helps us understand the self, the psychological makeup of the person. And the social aspects. You have the drift hypothesis, migration being a risk factor as such, family systems. So you get a wide array of models which can be used to fit in to explain the person's predicament. Let's see how we are going to do that. So the raw materials needed. We have the clinical reasoning, which we are good at. So, but only a thing which I would like to highlight is we need to focus more on the etiological hypothesis as much as we focus on the diagnostic hypothesis. So we have the matrix which you can draw the in 4x3. We have the etiological models which you can use from your knowledge base, linking the above. Then what we need to do is to seamlessly integrate. Now this is a skill. Well, it requires some essential knowledge, essential skill in use of language, and also analytical skill and high order thinking, which would come by practice. There's no shortcuts to learn that. So again, I highlight the importance of using formulation on a day-to-day basis. If you are seeing 5 patients, at least pick up one and then start formulating in a detailed manner and present to your consultant or the supervisor or the professor who might be in a better position to guide you further on that. So if you feel this is what is happening at the end of going through, let's say we all pass through this stage. Just remember the time when you entered your clinics in your second year, and then you had this entire steps in physical examination. Had inspection. Inspection has so many steps: palpation, percussion, and then auscultation. And there's this space. There's this, oh my goodness! Everybody you have to write and then tick if that has been done, and then present meticulously. And then comes the internship where you, by the time you come to tap, it becomes reflexive. So this is exactly what happens when a skill set is internal. This is exactly what's going to happen with a formulation also. The more you use, the more familiar you become. All right. So the art of formulation in that way is just the ability to link salient. Salient is an important word. You may have a lot of information, but your skill is also to pick and choose what is important and relevant for that particular person, gathered from the patient, of course, and from the family, with those theoretical models that have the most explanatory power. So what explains this best? You may have difference of opinion, but that's okay. What you think is the best explanatory model, and you try to justify it. That's it. That's your formulation, with the aim of achieving a seamless integration of the linked components. So we have the tapestry formed with various threads. You don't know where it is, various colored threads. At the end, you have the Bob Marley popping up. So exactly the art of formulation. That's exactly what happens in formulation. So let's see. How do we then develop structure for formulation? This is also important. Now, as I said, there's no hard and fast rule. I think there was a paper from, again, the CMC group, Dr. Kuruvilla and team about various diagnostic formulation sometime in 2010 or 11. Not really sure, but that's a good paper to look through. And there are other ones in ANZ Journal of Psychiatry as well. They actually looked at how frequently, in the paper from Velo, they have looked at how frequently formulation is being used and what are the consultants or the teachers' view of diagnostic formulation and how relevant it is there in the exam model. These are the questions which I think there's an excellent way, a paper which looked at all these aspects. Now, I primarily use what is the guideline from the Royal College of Psychiatry. So, I mean, it's something which can be developed upon. So it's not the perfect model as one you could argue, but it's a good one to start with. So the guidelines actually say that you could explain this in, just like you have MSc with clearly defined steps. It's good to have some structure. So section 1 could be an introductory statement that places the patient and the problems in context. Now we'll see how that can be done. Second part could be the main part. So that is where your important biological, psychological, and socio-cultural aspects of the history could be explained. Now, this is where you use your metrics. So you have all the points written over there. In the beginning phase, I would suggest draw that and then try to mark, not over there, and then use that when you develop the second part of the formulation. Now, in contrast to the preceding section, this section provides a more longitudinal perspective. So the first one gives a context in which things have happened. Second one gives a longitudinal perspective with all the precipitating, predisposing factors and perpetuating factors. So that's the timeline which I had showed you earlier. Now, the third part is where your skills again come into play. Now we have a lot of information. How do we make sense of this? That is exactly what is done in the third part, where you try to find linkages between the material of the section 1 and section 2 using hypothesis derived from an acceptable model or framework. We talked about the various models, biological, psychological, whatever. And it is to your preference as to what you use. Now, the model that you use is what you would use to formulate a treatment algorithm, a protocol for the management of the patient. So that is why the formulation helps the person, the clinician, to have a better outcome at the end. It's perfectly okay as to what you choose. Now, sometimes you may find that there are more than one model which can explain the person's predicament. That's fine. You can use one or two. There's no hard and fast rule again. Now, a cognitive theorist might say this is the only model. No, we wouldn't want to be rigid in our thinking. At least one of the essential qualities, apart from being open and willing to be uncertain, a psychiatrist, I feel, also needs to be little inflexible. The inflexibility is something which do not go in with us. So being flexible, being open to various possibilities, something which can help the person coming in and then to seek help from you, as well as you forming a better treatment paradigm for the patient. So the patient's vulnerabilities here, you identified it in your history, then juxtaposed with the current stressors. If you remember the example I'd given about a schizophrenia patient, patient with schizophrenia coming with a self-harm attempt, to provide a plausible explanatory statement. Again, you mentioned the patient's strengths or protective factors in the third section. All right, so coming to the final part, if there's an overview which you are clear about, essentially this needs a workshop approach. So we are going to go through, I think I have enough time to go through that, but just to go through what DSM-5 says about the formulation. So we can all breathe easy. Is that something required? Well, what does the DSM-5 say? The case formulation for any given patient must involve a careful clinical history and a concise summary of the social, psychological, and biological factors that may have contributed to developing a given mental disorder. Hence, it is not sufficient to simply check off the symptoms and diagnostic criteria to make a mental disorder diagnosis. It is well recognized that this set of categorical diagnosis does not fully describe the full range of mental disorders that individuals experience and present to clinicians on a daily basis throughout the world. Now, this is from the Bible. This is from Americans who think they are the leaders of the world, especially coming to psychiatry as such. But it also tells you the importance that we need to give during our training, during your learning, as well as teachers, our responsibility to help you understand what exactly are you going to face once you get into regular practice. So with that, I think I conclude the main presentation, but just to tell you, to probably give you a further perspective on this, when you are treating a patient, not only are you treating the condition in front of you, but also we are trying to prevent something else in the future. So if you limit yourself to only diagnosing a person as schizophrenia and then keep focusing only on the medication, then you probably are missing out some of the factors which cause relapse. You're going to cause, probably not going to look at the negative symptoms which prevents him from getting back to a workforce as any other person would do. You may even completely miss the psychosocial background that is maintaining the illness because of the inability to buy medications or the lack of cohesion between family members. So this exactly is the need of the hour, where you have a broader outview of the patient and then understand the context and the situation in which the problem is happening. This is exactly what probably Sherlock Holmes did when solving a case. All right, so I hope I can move on with one or two case histories. Professor, is that okay? Am I audible?
Yes, yes, you are audible.
Yeah. So what I would do is I probably give a minute or two. I could read through the case history and then probably give you a minute of time to just think about yourself how you would formulate with this background information that you have. So here's a case history. These are, by the way, they are real patients who had come to the clinic, but obviously name and identity is not true. It's been changed to preserve the privacy and confidentiality. So Maria was a 34-year-old lady from a middle socioeconomic status. She's a bag accountant by profession and a graduate living with a husband who is a businessman. I hope you were able to read through the screen answer, but anyway, I thought I'll just try to formulate as I go through the history myself. Two kids aged 10 and 5 years old. So she presented with a 3 months history of persistent sadness of mood, poor concentration, tiredness most of the time, early morning awakening, guilt, and blaming herself for being a poor mother. Now, she reported inability to handle demands at workplace and interact with customers and colleagues at workplace. She had fear of going out to crowded public places. Now, this is a pre-COVID era, so please don't confuse. With that, she also narrated many instances where she struggled to participate in social events and workplace discussions. She complained of constant thoughts surrounding her own inability to handle all the demands, lack of support from her husband in caring for her children, and increasing work stress. But she did not report any first-rank symptoms, obsessive compulsive symptoms, or generalized anxiety symptoms. No suicidal ideation. I have deliberately used some technical terms. Apologize for that. Many people are very particular about that, but this is just to help us understand and learn. There's no suicidal ideations as well. In a past history of the illness, 2 episodes of depression, first at the age of 23, followed by 2 others. There was a postpartum onset of depression 5 years ago, necessitating a course of ECT. The ECTs were stopped when she had a brief hypomanic switch. In the medical history, there was no thyroid dysfunction, nutritional status was normal, there was no medical comorbidity that one needed to be aware of or worried about. Treatment history, she was on sertraline 150 milligram. Quetiapine was on 50 milligram for the last previous 6 months. She was always adherent to medication and regular in a follow-up. Family history, both parents suffered from depression and were on long-term treatment. Elder of the 2 girls, mother suffered from severe depression and needed multiple admissions during a growing up period. Developmental history, that again is something which is not given that much importance in regular history taking in this part of our world. I think I would highlight again that it's something which is going to give you a lot of material to have a better formulation. Recalls being lonely as a kid, few friends in school, struggled a little being in a group, anxious with being the center of attention. Above average in studies, recalls being assisting her mother whenever she became unwell and being in the hospital when she was admitted, took up responsibilities from a young age, started doing part-time jobs from 18 years of age while continuing her studies. So married at the age of 22 to a husband who was a distant relative. So on medicine examination, this was a distraught individual looking a stage and age, fairly kempt, tearful during the interview, maintaining eye contact only intermittently. Rapport could be established with some difficulty. She had soft tone of speech, which was coherent. Decreased psychomotor activity was noted, and she reported feeling sad. a mood that was sad. She had depressed affect in the cross-sectional evaluation with decreased reactivity, restricted range, and it appeared congruent to her thought process. There was slowed stream of thought, so no formal thought disorder was evident or problem with the possession or control of thought. She reported feelings of worthlessness, hopelessness, and guilt, especially due to her inability to being a good mother. She did not report any persecutory or referential delusions, nor was there any hallucinatory experiences. She did not report suicidal ideations. Overall, I felt insight appeared to be fair, with she acknowledging that she was ill, attributing a difficulty partly to depression, and wanting to get better with treatment. Her judgment, at least on personal level, appeared to be impacted with the illness. Now, when you get such an history, which with lots of information, obviously, this is something which we all will be doing. I'll give you a minute of time to just think about, a minute or two, just to see how would you formulate based on these three structures, these three sections that I've thought about. And then probably you'll go through the models of formulation after that. You could use any model, but just try to make an effort to formulate. All right, so maybe I'll just move on to the next slide, which is just a kind of a sample of the diagnostic formulation, just based on what we have just learned or gone through that in the last few minutes. So I wanted to kind of consider a biological angle to it. I thought of recurrent depression, and then I thought of formulating it in a way which explains it in a biological way. So this is how I would formulate. So Maria is a 34-year-old mother of two preteen children. That's a background which is quite informative. Working in a bank, we know that she's employed and capable. Presence with recurrence of depressive symptoms. This is in the context of increased work stresses and the background of previous episodes of depression. So we have provided the context and the brief background. Now, if you are a biologist, you may want to focus that alone. That's perfectly okay. So she's vulnerable biologically. We know the genetic risk here. You have family history of depression. So that's the second section. The first section is section 2, where you use your matrix and you taking information from there. So you have the predisposing factor because of the biology. She's vulnerable biologically owing to the genetic risk with history of depression, both parents and her own history of depression. So we know one episode of depression in life puts you at risk for another episode, invariably. However, the hypomanic switch on ECT seems to suggest a bipolar picture and its linkage to circadian rhythm disturbances. That's the other biological theory which we can incorporate. Now, you may want to include some psychological aspects. She's predisposed to depression again because of her avoidant personality traits and probably a poor social skills, and isolated existence seems to be adding on to the problem. Now, the precipitating factor biologically, so you have some predisposing factors, the precipitating factors, biologically appears to be sleep deprivation and lack of rest due to increased stress at workplace. Her own inability to manage her anxiety and self-blaming nature stemming up from depressive cognitions appear to maintain a problem. So here with a perpetuating problem, which is explained again with the psychological and the biological model. Then comes the explanation. How do you find the linkage? The genetic risk of depression in the context of increased HPA axis activation. That's your model that you have. You're a biologist. So pretty happy with that. HPA axis activation appears to have precipitated a recurrence of another depressive episode, and the possible bipolar etiology seems to be the cause for inadequate response to treatment. Now, you are not only finding a linkage, but also you are trying to explain why she's not getting better with treatment fully. There's no full recovery. Bipolar etiology seems to be the cause of inadequate response to treatment, will make you think of a different treatment. So that is where the formulation will help. You have a differential diagnosis too coming in that way. So that puts her at risk more with circadian rhythm changes. So somebody works with shift system, you have a variable sleep pattern, you may want to ask them to change that. So however, willingness to participate in treatment and adherence to medication owing to higher level of intelligence and insight seem to prevent significant worsening. So here's a simple formulation which explains a predicament. Now, if you keep doing this more and more, you may develop a much more sophisticated way of understanding the person. As you further read and then have more idea about different models, and you may be confident enough to use further theoretical models which would probably better explain the larger context in which happening. So same formulation in a different way. So if you too sophisticated, then you should not go out of hand. But this is just to help you understand. It's not put in a particular order, but just to help you understand the various ways by which we could do that. So we could always formulate in this manner. An important theme that arises in Maria's presentation is the presence of strong biological predisposition, which is what we did earlier, to a depressive illness with a family history in both the parents. Additionally, her anxious temperament also predisposes to depression and anxiety. Her first episode of depression was at the age of 23, followed by 2 further episodes necessitating ECT. One of these led to a possible hypomanic episode. This, in addition to the episode of postnatal depression, raises the possibility of bipolarity, which might be contributing to the treatment resistance. This is a biological model which we have incorporated. As I said, you could use more than one model in a single formulation. It's entirely up to you. But as an exam point of view, clinicians or the examiners would be more than happy if you use one model and explain it appropriately. From a psychological point of view, I wonder how growing up with 2 parents with depression impacted on a developing sense of self-esteem. If you know the attachment theories and the growing up phase, how it can be impacted on self-esteem due to attachment difficulty and parentification. Many people may not be familiar with that term, but parentification is early taking up of responsibilities. Now, based on a cognitive model, if you can use another model here, it's reasonable to assume that this may left to dysfunctional assumptions of the self, with a tendency to self-blame and self-criticality, leading further to difficulties in negotiating the early challenges of childhood and adolescence. This would have then impacted on forming peer group relationship. You see, again, you are hypothesizing here what usually happens in such situation. Her current episode seems to be in the context of work stress and an inability to go out with her colleagues due to agoraphobic symptoms, which has impacted on forming social relationships, which further reinforces a sense of inadequacy and lower self-esteem. This again in the context of poor support from a husband and the pressure of work. So there's a complexity that you bring in your formulation. You can also wonder how her depression has impacted on her being a mother, which parallels her own early childhood. Now, this is a dynamic understanding. If this reinforces a feeling of guilt, further contributing to the depression. Now, her symptoms are being maintained by social isolation, anxious temperament, self-critical evaluation, unsupportive partner, and difficulty coping with the children. Fortunately, she has positive prognostic factors, which include compliance with medication, absence of drug and alcohol misuse, and absence of overt maladaptive personality traits. All these would have had a different trajectory if she has been experiencing any of those things. So this is a much more integrated formulation, which has used multiple theoretical models. Now, you need not go into all the models in one formulation. You could use which is comfortable, but sometimes one could better explain, and you may have a treatment which is appropriate in that fashion. Let's move to the second one. I'm not going to, this is just to again understand, not waste much time thinking about it, but just to give you an idea. What about a person with psychosis? This is again a client, a patient in our clinic. It's a 40-year-old man living with his parents, in the 70s, unemployed currently, with completed BA to correspondence, Then he hails from a middle class background. He presents with a relapse of his illness characterized by increasing hostility towards his parents, irritability, muttering to self, arguing with his neighbors, and poor sleep at night. On interview, acknowledged that he has not been feeling well for the previous 2 weeks, that he had missed his medication for 5 days. He complained that his parents never wanted him to succeed, berides him often. He also reported that he was unnecessarily being commented upon by the neighbors. And then he takes pride in his ability, takes pride in scaring him. He did not report depressive symptoms, but acknowledged that he has been feeling overwhelmed by the continuing stressful environment. He did not report thoughts of self-harm or any physical discomfort, but there was no substance abuse as well. His parents reported being at their wits' end, trying to get him to improve and change, and worried what would happen to him after the time. That was a concern. They're in their 70s. The psychiatric history showed first episode of illness at the age of 19. While in college, he had multiple relapses in the context of non-adherence to medication. Fairly continuous in the last 10 years history of illness with incomplete recovery, good functional ability in the initial few years, but showing signs of declining socio-occupational functioning in the recent years. Difficulty in concentration prevented him from continuing his tasks for more than 5 to 10 minutes. The treatment history, he was currently on amisulpride 400 milligram and mirtazapine 7.5 milligram. Medically, he was overweight, does not have diabetes, hypertension, luckily. Family history, there is only child or parents history of mental illness in the maternal aunt, suggestive of schizophrenia, no neurological illness. Both parents have diabetes mellitus. Mother feels she is partly to be blamed for his illness. She was expressing guilt. The development and personal history, he was born out of cesarean delivery owing to good cord around the neck. There was no developmental delay. Shy and aloof child who took time to engage with people. High expectations from his father, who was also a strict disciplinarian. Scholastically average, scoring around 70% in his 10th, 60% in his year 12. He had to discontinue studies during his first year of college, completing his degree much later through correspondence. He harbored hopes of clearing his MA exam and pursue a career as a teacher. So on mental examination, he was an overweight man, looking older than his stated age, was fairly kempt. He was cooperative for the interview. Rapport could not be established. So it could be established, albeit with some superficially. He was noted to be fidgety, avoided gaze intermittently. At times, he muttered to himself. His speech was relevant and coherent and goal-directed. He described his mood as great. However, his affect appeared blunted and incongruent to his conversational themes, exhibiting a constricted range. The stream and form of thought were normal, showing no evidence of a formal thought disorder. Sorry. He also reported being disowned by his own parents, complained, attributed his problems to them and their attitude, and the problems created by his neighbors by who were commenting about him continuously, suggesting hostility and persecutory delusions, as well as auditory hallucinations. He did not report his mind or body being controlled or his thoughts being known to others. There were no thoughts of harming to self or plans to take revenge on his parents or neighbors. Cognitive screening demonstrated impairment in attention and in view of his performance in digit span, serial subtraction, and finger tapping test. Overall, his insight and judgment appear to be impaired. So here's a fairly typical patient with clinical diagnosis of schizophrenia. But how do we then formulate his current presentation? So this is how we understood him. So he's a 40-year-old single man on disability pension, 10-year history of chronic schizophrenia. He lives with his parents. Over the last 10 years, there's been a progressive decline in his overall level of functioning, with relapses of acute symptoms occurring with stressful events in the family or non-compliance with medication. His family has responded to his illness with what appears to have been either overprotection or alternatively with denial and rejection. Now both are known to create further problems. He currently presents following an altercation with his neighbors and aggressive behavior at home in response to abusive auditory hallucinations and paranoid delusions involving them. So he was a shy child, only son in the family. He was often aware of an expectation from his father for him to achieve. The history that a maternal aunt suffered from a psychotic illness may indicate a genetic predisposition. So here you have talked, including the biological theory. It also appears to have caused guilt and self-blame in his mother. So Ram's increasing withdrawal in adolescence may have been a reflection of family pressures dealing with the task of adolescence or the first signs of illness. It could be a prodrome. Again, you're looking at the longitudinal pattern. Ram formed few friendships, had been failing in his studies. With the continuation of the illness, he failed to develop the skills for relationships and independent living and continues to rely heavily on his family. Then we formed the third part where we try to find these linkages and explain. So he continues to plan unrealistically for a future in which he will study and complete his MA. He had written exams for almost the last 6 years, many times, one paper at a time, never cleared yet, and develop a successful career as a teacher. He's very reluctant to attend a rehabilitation program. This reflected his difficulty in accepting the limitations of his illness and perhaps also the unresolved need to meet his father's high expectations. He formed this dynamic model of illness. We use that in explaining the person. It appears that parental guilt and grief over Ram's illness lead them to reject him at times. This is often compounded by Ram developing persecuted illusions about the family. When he attempts to work as a data entry person, his cognitive difficulties, especially poor attention span, causes difficulties with sustaining his job, and his family demands that he stay at home. He experiences his demands as over-controlling and feels criticized. Thus, both of the family's responses to his illness, either rejection or protection, appear to contribute to a high expressed emotional environment predisposing to relapse. So this is a well-known model of relapse in schizophrenia, but you understand the context in which it's happening and use that in your formulation. So the final slide is, suppose this is what I do in my specialty clinic in Ramchandra. We have a memory clinic. What about dementia? Can we have a formulation for a person coming with dementia? I've not given the history. I just read out the formulation just to help you understand. It can still be done, and we can still provide a meaningful response to a person with such an incurable illness, which you know is going to deteriorate. There's no disease-modifying agents in this condition. So what about Mrs. Radha? She's a 72-year-old teacher who post-retirement is running a play school. She was so fond of children, she insisted that there's no problems which required a consultation with me in the memory clinic. So while she could answer direct questions, she lacked spontaneity and her answers were slightly vague, lacking depth and detail, which you know is a feature for the dementia. Putting that in context. On direct questioning, she admitted to memory difficulties for some time, which were confirmed on cognitive testing with deficits as outlined previously. The details of her problems were narrated by a son and daughter-in-law who were worried about a decline in memory and ability to live independently and increasing irritability. So she gives a history of somebody who had a happy childhood and as an adult has been a well-loved teacher, an active member of the local temple committee and a responsible wife and mother. She had been happily married for 45 years, but described herself as lost since her husband's demise 2 years ago. She denied any significant medical or psychiatric history. On brief physical examination, she was noticed to have poor dental health, poor and blood pressure of around 150/100. She acknowledged a weight loss of 10 kilograms. Now, this I've added just to give you the extent of biological factors which might be contributing to a decline in functioning in dementia, which is not usually looked at in detail most of the time. The patient was aware of her cognitive difficulties and had some insight into her disorder. However, she tried to minimize her problems in front of her son and daughter-in-law. It appeared that she was in denial. So you use again a psychological model here, or more as an attempt to prevent closure of her play school. So this is which has given meaning to her, and then acknowledging she is unwell, and this might make her lose that only last straw, which kind of maintain a self-esteem. That's one way of understanding her, which has helped her cope with grief and maintain a financial independence. Now, she was not severely unwell, mind you, so she still retained some insight into her problem. She was aware of her cognitive difficulty. Clearly, the illness entails multiple losses for her, and the sad effect and tear. Sorry. I have a very young listener, I guess. That seemed to represent more a process of grief and bereavement rather than organic emotional ability or major depression, which is what you would consider as differential diagnosis in a person coming with cognitive difficulty in an elderly individual. Also, the latter requires exclusion. Similarly, anxiety seemed clearly related to fears concerning her own future. Now, what did I hypothesize? I would hypothesize that Mrs. Radha may have been suffering from cognitive difficulty for some time, which is most of the case in our country. Many times it would be rubbished as, or denied, or just ignored as an elderly person, part of aging, memory disorder, memory problems as part of normal aging, and then not given adequate importance. So, and a husband possibly protecting her in a practical way. He must have been an extremely capable man, highly efficient, organized, which would kind of, and he would have overdone most of the things to maintain things in order. His sudden demise both removed that practical support and acted as a major psychosocial stressor, precipitating her own deterioration in functioning and highlighting her inability to live independently and a worry about losing of ability or caregiving ability or a role as a teacher. So that kind of gives you an idea how we understand. So what did we do for this patient? I've highlighted that treatment component in your clinical reasoning is not explained here. That's by itself. So we need to develop something which is appropriate. So what we did was we just ensured that she had supervision throughout, and then helped her maintain that school with a new teacher in. So she felt she was still being valued. She could be there where she enjoyed being there all her life, and then maintained a role, and which gave her much better improvement in the the depressive symptoms. Whereas the risk of deterioration and the implications of further worsening was explained to the family and her in detail, and she completely accepted that. The crisis at that time was averted. I think I will probably end with that. I sincerely thank my team over here for continuing to help me maintain my learning process. That includes my junior colleagues at Ramchandra Institute of Mental Health, Chennai, and Kilpauk Medical College, and my dear colleagues who have been more than capable in participating and continuing the learning process. And also a big thanks to the organizers for having given me this opportunity. Thank you so much.
Thank you, Dr. Jayakumar. And I'm happy to know you have given us a very, very comprehensive and yet very holistic perspective to a diagnostic formulation using this particular kind of model. Though the hardcore biologist would be cringing, I assume, but we leave that debate for another day. I'd be happy to have some questions. We have Abhishek who has asked a question. Case formulation and diagnostic formulation are the same or they interchangeable?
Right. I think it's just another, I wouldn't find much different. Now you need to differentiate a case summary and a case formulation. So it's a word formulation is more important, whether you call it a diagnostic formulation or a case formulation. Ideally, again, I would say since you have asked that question, a case formulation would sound better word than a diagnostic formulation, which would give us understand the nuances of the whole process, where you don't just limit to one particular diagnosis and one particular treatment, which is, as Prof said about biological treatment alone, which may not be always possible in most of the cases. Yep. I hope that answers that question.
Right. Let me check. No, I think that we don't have any more questions. So clearly you were very lucid to the point where there was no issue left for debate.
I want to believe
it was definitely very enlightening. Let me ask you this: how is this different from RDoc? I mean, just to kind of round it off, I think we lost your voice.
Sorry, could you just define? I'm not really sure what RDoc is. Yeah. So you may have to. So you're talking about a research diagnostic.
Yes, yes. So that is obviously relatively preclinical at the point at which you might actually start treating a patient, and this, in that sense, is more bedside rather than bedside. So but what is your take on it? How would
Yeah.
this differ? Because
See,
there are people who have an extremely biological approach, and
yeah.
they perhaps do not give adequate amount of significance, or do not believe in this kind of an approach as much anymore, because we are becoming more and more biological with every progressive year. So,
Yeah.
what is your take on that?
Yeah, in fact, I completely agree with that. You see, the whole idea of having a strong biological basis is not antagonistic to you formulating a person's problems. Now, you may be a biologist who may want to pursue that angle. As I said, the formulation that I showed you, uh, the first one was purely a biological way of understanding depression. Now, but the major problem which we find, and I tell you from my experience, having worked in different settings, even in different institutes, where there's a national institute, there's a center which is a general hospital with psychiatry setting, and overseas setting. What I find is where there is active research happening, then people tend to conclude uh, and be familiar with only that aspect of care. Now, when it comes to a larger context, when it comes to practice, they don't realize the life beyond the training phase. Now, the first exposure to that came up. I'm trying to put that in context. Happened in St. John's Medical College, where they had a strong multidisciplinary approach to care, and still do. They have an excellent department of psychiatry where most of the different departments sit together and then discuss cases. That's the first exposure, as far as I'm concerned, to look at the larger context in which we understand the problem. Now, when we moved overseas, when some of my colleagues and my close friends moved overseas with the Royal College training, none of the exams would want you to tell you only the diagnosis and the medication. That's not what is expected. They wanted you to explain to them, even in the observed clinical interview, mind you, just to explain how would you manage this patient, and you have to explain to them what you understand has what the person is, the larger context in which is happening, the system which are available to provide support, and how you as a clinical lead will organize that. So this can come from we understanding the larger roles as a professional. So the CanMed model is what I would suggest everybody could go through. They have a role as a communicator, collaborator. There's a scholarly role. There's a professional role, medical professional, which talks about the treatment part. So these are different roles which we need to carry as a clinician. Now, many times what I find is a big lacuna in our training system, and which is carried forward as we complete our training also. Now, is that absolutely wrong? I wouldn't say it is absolutely wrong. As we know, nothing is completely wrong or right. But in the larger context, when we don't have the community mental health systems, we don't have adequate professionals to work, the psychiatrist has to identify what other roles need to be done, need to be met with a particular person presenting to you for consultation. Now, it is far easy to diagnose in 2 minutes clinical depression and focus only on the medication. That is what most of the practitioners would do when they come out of the training. But unfortunately, more often than not, it can lead to issues. So that's where how I see this. So in your training period, if you are a person who does that, you are welcome to do a purely biological approach. And I do a purely biological approach in my neuropsychiatry thing. It just doesn't contradict my understanding of my attempts to understand the person in a larger context, even in
Right.
neurological situation. Yeah.
Fair enough. Fair enough. So I understand. So then the perspective is different. The patient may be the same, and both of them can coexist. They're not necessarily in conflict with each other.
No.
Okay, fair enough. There is a question. Other than the matrix that you showed, is there any other tool by which we can sharpen our skills in DF, which I am assuming is diagnostic formulation? And how is diagnostic formulation different from summary?
All right. So, if okay, the first question, the matrix is only for learning. Let's say it's a kindergarten level. Let's put it that way. So I told you, there are various models, and I don't want to confuse you with various different models. You can refer to that famous the article that I mentioned from the Velo team. They have kind of looked at how different diagnostic formulation models could be there, and various things which are available. Now, formulation is an essential component in your psychotherapy setting. So if you go to a psychologist and ask how do you formulate your patient, if you're a person with a cognitive therapist, they have a cognitive model which they use. So they have the structure which is already there. Now that is perfectly okay. So that's what I said. There's no hard and fast rule do it in a particular manner. Now what Royal College has done in their training program is to incorporate different models. So there's no conflict as to one is better than the other, which is why I said, it doesn't stand against. The formulation only helps us understand things better. If you want to use any particular different model, that's perfectly okay. But the matrix is only to give you or help you identify things easier when you do the initial attempt at formulation. When you start seeing patients and then try to develop the formulation on your own. So that gives you easy to cherry pick and then put it there, and then you use the same structure. Now, in a college examination, where an observed clinical interview is no longer there. It's only OSCEs, even in the UK exams and in Australia, but the US still has the observed clinical interview. The system is so different. You are just you're just sitting there. You walk into the room. You have two examiners sitting behind you. You won't be able to see them sitting behind you, but they observe what you're doing. The patient is brought in. You have 50 minutes to the interview. You don't know anything about the patient. Examiners do not know anything about the patient. You get all the information, and in the next 20 minutes, you are asked to give a succinct summary of the case. You get a 20-minute thinking time, and you're about to give a succinct summary. The succinct summary is just like how you present your case, but it may not be a long presenting illness component. So summary is just salient points, which includes all the Megros items, including the past history, development history, family history, all those aspects. And then there's a separate component. You're supposed to give a succinct summary. Then you're supposed to give a mental state examination findings by itself. That's your core skill. Then a formulation, and then subsequently a differential diagnosis and a diagnosis. So formulation is an essential skill which is kept separate from you summarizing. Everybody can find a summary. I've summarized, you can repeat it. You take an history, you can summarize salient points. But the formulation essentially is given as a separate entity which explains that particular question. Why does this person comes with this particular problem at this point in time? So that gives you a larger context in which things are happening. And I guess that's how it is different.
So in that sense, it might be fair to say this is more about your clinical skills rather than your academic skills, and how you are able to assimilate your clinical and academic skills in being able to understand the case and be able to draw up some kind of a plan for the future.
Absolutely, absolutely. So then the next component in the exam, after 10 minutes of you presenting this, is I think it's a challenging exam for many people. And let me also be very honest about it. Most of the people who moved from India overseas, who have attend the Royal College exam, the biggest challenge is to make this transition from a diagnostic, simple, linear causation model to understand the comprehensive picture of the patient and explain that in a way that is comprehensible to you and the person and this. So the next component of the exam is to have the next 20 minutes. You need to explain. 20 minutes is for your initial this part of summary, MSc, formulation, and this. And some of the risk component is also highlighted. Risk is a separate component. What are the risks that you identify? And the second part, 20 minutes, is to develop or you explain a succinct, comprehensive treatment plan for that particular individual based on your formulation, based on what you've identified. There again, it is not like a knowledge. You can quote the entire Kaplan, you fail. But what you would
So then in that sense, to call it a diagnostic formulation wouldn't be a bit reductionist? Because diagnostic formulation essentially is a little bit of a cross-sectional perspective. And what you have enlightened us with during the discourse is to be able to look at it as a linear continuum rather than just a cross-sectional perspective.
Absolutely, which is why I said the first, who I don't know, forgot the name of the person.
So it's more of a clinical formulation rather than a diagnostic formulation.
A clinical formulation would be a better way, because the whole idea is to go beyond the diagnosis. But yes, why we use that is because of ease of practice, and then to understand, we don't forget the diagnosis also.
Of
Not
course
like,
not. Of course not.
no, not that way. Yeah.
So you
So
build around the diagnosis, but you incorporate the past as well as comprehensively plan for the future.
Correct, and have explained it in the context in which it is happening right now.
Sure.
So which will give you formulate a much better personalized plan. That's all. It could be purely biological, but it might be as simple as that we are doing a study. We are discussing with the postgraduates, first year postgraduates in Madras Medical College with my friend Vijay from SCARF. One of the PGs had come up with an idea. Why are we not using depot medications better? Now, you diagnose schizophrenia, you take medication, but if you have a formulation which tells you this, your individualized treatment would invariably think of depot as one option, which is as good as the same medication, and you find a much better outcome. You're using a biological model alone, but think of that. But otherwise, you keep prescribing, and the person keeps stopping medication, and that's a practical difficulty which you might face. But there's only one simple way of understanding that.
True. I think that's a very apt analogy. We have one. I don't know if this is a question or a comment, but this is the last one we'll take for the day for the paucity of time. Somebody under the name of Realme 5 Pro writes, so while biology pitted against psychosociology, I mean, at the end of the day, brain is a biological system governed by the law of physics, and psychosociology acts on it, the diathesis stress model, to precipitate a disease. So treatment needs psychological interventions as well, like social support, help groups, intercommunication skills, all needed to synchronize the neural circuits. I'm a biological psych, but just don't get this synonym of biology with pharmacology. I don't know what exactly are you trying to say, my friend, but you have put in a very complex kind of postulate. So I will let.
But I guess he's trying to probably. I'm trying to hypothesize here. What he's trying to do is to see the larger context. We not reduce it to just pharmacology, the larger biological system which are affected. Exactly, that's perfectly okay. But you're just again trying to highlight that sometimes relaxation training is much more important in preventing relapse than once you complete a course of treatment. The person accepting a lifestyle change, educating them, if you see that in your formulation, this is an important thing for that person, is more important in preventing relapse. That is all that we are talking about. So you understand the context in which is happening. A circadian rhythm disturbance, some person doing shift work, you keep prescribing mood stabilizer lithium, and then he gets unwell every 3 months. You wouldn't think of it unless you inquire a bit about his work. He wouldn't tell you unless you spend some time about this. This is a larger context which we need to do, and your formulation helps in understanding that.
Which any which way, all these factors have biological correlates at the end of the day. So in that sense, it is biological at the end of the day.
Yeah, fair enough.
Right. Okay, great. Thank you very much. The audience has been a little patient with us. We have overshot our time, but I thank all of you for having been with us, and we are grateful once again to Dr. Jayakumar to have taken the time out and been with us today and share his thoughts on far more holistic perspective of how to handle a patient, treat a patient, and plan for the future, so that we can give a more comprehensive and a more gratifying outcome on the long run, rather than just dish out a prescription. So thank you very much once again, Dr. Menon, and it was really nice to hear you. And it would be remiss on my part to not acknowledge the support of Sun Pharma, which has been unconditionally supporting this academic activity for well over 5 years now. And of course, the postgraduate students and all the now senior psychiatrists as well who join us in this program. It's for you. In that sense, this is like a democracy. We are hearing a lot about it in the last couple of days, so I can borrow from that example. It's for you, by you, and I hope that we continue to enjoy such discourses together in the future, so we can improve our knowledge base and also come on a common platform to be able to exchange ideas. So thank you all once again, and Thank you, Dr. Menon, on behalf of all the postgraduate students of the entire country now, as well as some senior faculties as well. And we hope to have you back on this platform sometime in the future. Right?
Oh, thank you so much. Thank you so much. It's been a pleasure.
Thank you very much, and thank you all. Good evening to you.